I did have fun in New Jersey. Yeah, we had a good time. It was cold when I first got there, and then it started to warm up. So.
Did you eat a lot and regret it?
I did, and you know, I did get a chance to go to White Castle.
Did you?
Go on.
Yeah, I didn't get a chance to go to White Castle, but it's okay. So, speaking of White Castle, GI disorders. So, chapter 36, we're going to go over all of the different types of GI disorders. This chapter is quite long. In the beginning, we're just going to go over some basic physiology, some basic terminology of things that you need to know for some of the diseases. And then we'll just get right into all the diseases. We'll pretty much take it from the beginning of the GI tract, starting in the mouth, and then all the way down to the rectum. Okay? So, the first terminology here that I do need you guys to know, which you probably know this already, is dysphagia, difficulty in swallowing. So, individuals that have the inability to initiate swallowing, sensations feel like solids or liquids are stuck. Okay, so stuck, and I'm quite sure you guys know what that feeling kind of feels like. And also another term called omniophagia, which is painful swallowing. Painful swallowing. So sometimes people can have difficulty swallowing along with pain. That picture, I'm sorry, is not supposed to be there. We're not there yet. So. Now, there are 3 different types of dysphagia, and I do want you to know the 3 different types. And it all depends on the location of where the food or the liquid is stuck. Okay. So, problems with delivering food into the esophagus, this is considered to be type 1, okay, type 1 dysphagia. So you know when you learned in anatomy that we do have what is called deglutition, which is swallowing. And if you remember, there's 3 phases of swallowing. Do you guys remember those phases?
What?
Kind of, sort of. The 3 phases of deglutition. So remember, there's 3 phases of deglutition where you chew your food, you form your bolus, and then it goes from the mouth to the oropharynx, and then it goes down to the esophagus, and then esophagus to stomach, okay? So remember, there's 3 phases. So this is pretty much the same kind of concept here. So problems with delivering food into the esophagus, this can be caused by sometimes if there is a sort of neuromuscular disorder. So say, for example, the nerve innervation is not correct, okay? That will not cause this, the esophagus to actually pull or cause peristalsis to occur. Or there's a normal sequence, the normal sequence is altered or absent. Symptoms. Patients may cough or expel the food through the mouth or the nose, okay, and some people do this as a trick, but what happens when the food is stuck, it has to come out some orifice, okay, and the closest orifice is the nose, okay, or the mouth. Or sometimes people can aspirate these materials as well. They say this is worse with liquids than solids because the solids are actually more contained than liquids. Liquids, as you know, just kind of go everywhere. And unfortunately, this situation sometimes, and those of you that may work with patients may have already experienced this, sometimes patients can sort of cough on you and expel food and things on you. And not that they're intentionally doing this, but just out of uncontrol. Type 2. Type 2 is a little different, whereas the problem is the transport in bolus. So the bolus that's in the oropharynx is now trying to get to the esophagus or down the esophagus, but it gets stuck somewhere or something is causing it to not move forward. Okay. So they give you some causes here, something called the diverticulum. Diverticulum is, say for example, if we look at the GI tract and the GI wall, as you know, has 4 layers, and we'll go over that in a little bit when we get into, I think, ulcers. So 4 layers of the GI wall. Keep in mind that the GI wall, if for some reason it starts to weaken and causes like a pouching situation, as you can imagine, as you're eating food and food is moving down the GI tract, it could get stuck in that pouch, okay? So obviously that will cause an issue. Also, if there's a problem with the smooth muscle, if the smooth muscle is not moving properly as far as what we call segmentation, if you remember the process of segmentation. So if that smooth muscle is not contracting enough to push that food forward, or if there's also interference with peristaltic activity. And sometimes individuals can have a tumor, or I should say a cyst or things like that that could also cause an issue or blockage from that food not moving forward. Okay. So the sensation here with type 2, it is a little lower. So patients feel like something is stuck behind the sternum. Okay, so pain in this region. Now with type 3, this is now the bolus now entering into the stomach. One of the main causes they say here is a lower esophageal dysfunction. We will go over Gerd in a lot of detail, but this is different from Gerd. In this situation, this is where the lower esophageal sphincter is not opening enough to get the bolus to get down into the stomach. Okay, so these patients will have a tightness or pain in the substernal area when they're swallowing. And I'll tell you a funny story. I always have a story. This happened to me like this past weekend. I went to some restaurant eating, and right after I finished eating, I don't know if it was a bolus or what was going on, but I felt a lump in my throat, and every time I swallowed, it was really, really painful. So I Googled everything. So I Googled like, okay, bolus stuck in the throat. So in any event, they were saying to drink hot water and do all these things. So I kept drinking and swallowing, and I kept eating to push it down. So for some reason, bolus or food can get stuck. So I was experiencing a type of dysphagia, even though I was still able to eat my other food, but that particular piece of food got stuck. Okay, somewhere between my oral pharynx and the pharynx. So that was happening to me. So I did experience dysphagia. It finally went away. Okay, now moving from the mouth, okay, we're getting into the esophagus. Oh, this slide here you don't have to worry about. I'm going to show you some pictures of those. Okay, so heartburn. Firosis. So heartburn, I'm quite sure we've all had that feeling at some point, okay, in life, heartburn. This can be definitely caused by the reflux, obviously, of gastric juice, okay, or gastric material that is leaving the stomach, splashing up into the esophagus. Obviously, heartburn is one of the major symptoms that individuals do have with Gerd, okay, as you know, and we'll go over Gerd in detail a little later on. Now, symptoms, they do have substernal pain, but this pain can also radiate to the neck and throat. So sometimes when patients have this heartburn feeling, it can unfortunately sometimes mimic a little bit of sort of the angina. Okay, they're thinking they may have angina or maybe having chest pain or MI, but in essence it's really just heartburn. Okay. Even though the difference between chest pain, just regular chest pain, and heartburn is with the heartburn feeling, it is a definitely burning sensation. Although people kind of confuse it if they have the radiation going on. Okay, so chest pain, they say similar to angina pectoris, where it radiates to the neck or shoulder, brought on by swallowing. So sometimes with a person that may have experienced a dysphagia, if they continue to have this pain, it can start to have now this sort of chest discomfort. Again, this is something that can be confused with the angina pectoris that is associated with cardiovascular, but this is mainly some sort of GI disorder giving this situation. Now, abdominal pain. Okay, abdominal pain, we do have 3 different types, and I will give you examples of each one. With type 1, I should say type 1, but the first type here, visceral pain, the cause here is when there's some sort of stretching or distension of the abdominal organ, okay, or inflammation here. I had an example of that here. Oh, okay. So say, for example, if a person has some sort of distension, I'm sorry, I've lost my train of thought with the example that I had. But say, for example, if a person is experiencing some sort of gastritis, okay, where they're eating some sort of food and that food is giving them whatever type of bacterial infection, whatever is going on in their abdominal cavity, and the stomach starts to stretch and now go through the whole inflammation process because of the bacteria that they have there. So this will give them visceral pain. It is diffuse, poorly localized, but they do have sort of that cramping, you know, sort of burning, gnawing pain in that region. Okay, so gastritis, I kind of have an example for that. Now, the next one we have is somatic pain. This is when there's an injury to the abdominal wall, peritoneum. Symptoms here can be sharp, intense, well localized in the area of irritation. Very good example of this is appendicitis. So say for example, a person has an appendicitis, the appendix, and especially if the appendix bursts, okay, this can definitely cause a very well localized pain. And you know when people do have appendicitis, it is right at McBurney's point, okay, and they can feel that. Okay, and then when we talk about referred pain, this is felt at a location from a source of pain, and usually this follows a root of dermatome. Very good example of this, they say it's sharp and well localized, when people have kidney stones. So the kidneys, as we know, are retroperitoneal, okay, but when they do have these stones, because of the orientation of the kidneys and the ureters, they will start to have that sort of flank pain, okay, that goes along with that. So that's a very good example of referred pain when we're talking about kidney stones. Now, abdominal pain can be acute, okay, or chronic, and we will go into some of the different acute and chronic disorders. Acute is instantaneous onset. Keep in mind that this can come from, most of the times, are types of itises, so whether we're talking about appendicitis, gastritis, gastroenteritis, any of the itises. Also, if we're talking about a ruptured organ, okay, so like I said to you before, if a person has an appendicitis and unfortunately the appendix will sort of burst or something like that. Chronic is when we talk about chronic GI disorders that happen from months to years, such as a diverticulitis and ulcerative colitis. Okay, and we will go over those in a little bit. Now, vomiting. Okay. Vomiting, one thing I do want you to know that's not on this slide is that vomiting can be accompanied with nausea. Oh, they do have it. It can be accompanied with nausea. Nausea is the sensation or the feeling that you have to vomit. And please keep in mind that sometimes a person can just have nausea without the vomiting or both. Okay? But usually the nausea will precede vomiting if that person is vomiting. So this is a forceful expulsion of gastric contents. Please understand that vomiting is actually what we call reverse peristalsis. Okay, so when you know peristalsis is food moving forward, whereas this is the reverse. Causes here can be, this is reverse peristalsis. Causes here can be coordinated abdominal muscle contraction with the reverse peristalsis. Usually what can cause this if there's any type of bacterial infection. Keep in mind, even when your body, in vomiting, some people, I know my sister, she hates to vomit. Some people kind of are squeamish with that. But keep in mind, vomiting is actually, I don't want to say a compensatory mechanism, but it kind of is with the GI tract because it's your body's way of getting rid of whatever that's not supposed to be there, okay? So if it is a gastroenteritis, if you are experiencing a bacterial infection, as you know, common sign and symptom of that is vomiting and diarrhea. It has to go out somewhere, okay, because your body cannot keep that bacteria in the GI wall. So just keep that in mind. Vomiting is not a terrible, terrible thing. Okay. Now, gas. Yes, we have to talk about gas. Now, with gas, yes, people do get intestinal gas, okay. And what causes intestinal gas, if you ever wondered?
Taco Bell.
Taco Bell. Yes, Taco Bell. A lot of other foods. But what really causes it, as far as the physiology of the GI wall, is actually the fact that when we lack digestive enzymes, what will happen is, say for example, let's just take people that are lactose intolerant, because that's an easy one to take. when people drink milk products and dairy products, what will happen is that the body doesn't have the enzyme to break down that lactose. So what will happen is that particular lactose will actually sit on the GI wall. It'll just sit there. Now, how is the body going to get rid of it? It can't just sit there and stay there forever. It actually turns it into a gaseous state. Okay, so it does have its way of breaking itself down, and especially because it's in an acidic environment to begin with, so it will turn it into a gaseous state. Hence the reason why, you know, when people are lactose intolerant, you don't want to be around them if they haven't taken their little pill, okay? Because they will have a lot of belching and flatulence and all that good stuff. Okay? So, belching, we already know what it is. Okay? Causes here, gastric outlet obstruction preventing the passage of air, okay, from the stomach. Another thing with belching too, and I'll tell you a crazy story. I have a girlfriend, she actually just had surgery with this, but she had very severe fibroids. She actually had 26 fibroids. So when she had her surgery done, she had 20 taken out. Six were still left inside that they couldn't remove. They had to go back in later on. So in any event, because of all these fibroids, and if you've ever seen women with fibroids, especially if they have very large ones, they almost look like they're pregnant. So her stomach was very large. And so anyway, make a long story short, because of all of the fibroids that she had and the size and everything, it was actually pushing against her abdominal organs. So she had a lot of belching. She would belch like, I would be on the phone with her like every 10 minutes. She's like, oh, belching. And I'm thinking, how is she teaching? Because she teaches like I do. I can't imagine her classroom. But in any event, the point of me saying that is that the belching can not only be a result from, you know, the lack of enzymes, but keep in mind too, any type of constriction or pressure that's on the abdominal cavity too can cause that air to just be forced, okay, to cause belching. So keep in mind it also can be from obstruction. Okay, so causes again, swallowing of air we talked about, digestive activity, diffusion from blood can do it too, and neutralization of acids, which we also talked about. Okay. Now, as abdominal distension, what is this? This is just a fancy term for bloating. Okay, so abdominal distension just means bloating. This can be, yes, from gas, okay, excessive gas, which we talked about already and how that develops. PMSing can do it. Well, with that, it's more of the water retention that causes that feeling of bloating, but it's more the water retention. Flatulence, we already talked about this again, so any type of gas, and because of the action, the bacteria can do that. Beans, vegetables, we already know. Now, constipation. Constipation is what we call decreased peristalsis. Okay, so if you want to jot down decreased peristalsis. So decreased peristalsis is when everything just kind of slows down. Okay. Constipation, small, infrequent difficulty bowels. They give the causes here. As we know, low fiber is definitely one cause of that. Lack of exercise, and especially if people have different types of conditions going on. Also keep in mind that constipation is also quite common amongst the elderly. Keep in mind with metabolism. Metabolism is one of the things that do slow down as we age. And so what happens, you may notice if you do work with geriatrics that they may start to have just constipation for no reason, but the reason is because their metabolism is slowing down, which will in result give them a decreased peristalsis. Okay. This picture here, I don't know why it's sort of there, but I don't need to go over that. You guys know how we break down fats, and do I need to review this? You guys. Okay, now diarrhea. Diarrhea is increased frequency, and keep in mind that this is going to be increased peristalsis. Okay, most of the times, yes, this is from an acute infection, as you know, so gastritis, gastroenteritis, what have you. Emotional stress is very true. Okay, people don't realize that, and I've even heard of students having test anxiety, and I'm quite sure you, if you haven't experienced this, probably know that it will increase your ability to go. okay? Because everybody's gonna get diarrhea. Okay, I'll explain. So what happens is when you are stressed, what it does, it actually kicks in your sympathetic nervous system. When your sympathetic nervous system kicks in, it increases everything. So it gets everything moving, which the result of this, it will increase your peristalsis. So it'll get the diarrhea. Can be a result. Okay. So, and believe it or not, that is true. I remember, I think I told you guys, I used to teach a class when I was in New Jersey. In the Anatomy and Physiology book that we had a whole chapter on stress and how stress can affect so many different things people don't realize, and it actually goes through the whole physiology of it, which was really cool. Okay, so in any event, that's diarrhea. Okay, so chronic diarrhea can come from a number of things. Chronic GI infection, malabsorption, which we're going to definitely go over. So sometimes people do have malabsorption issues where certain foods that they eat, they cannot absorb. And what is the body going to do? It's going to get rid of it. Okay, it's not going to sit there. Food allergies kind of go along with that. Caffeine, okay, just to point out a few. And most of you guys that know, especially you coffee drinkers, some people drink coffee just for that reason, to kind of get themselves regulated. Okay.
It's nature's put.
Yeah. Because coffee will increase peristalsis. It's just one of those things. Okay. Now, that was fun. Okay.
You should put that in your PowerPoint.
Need a restroom break after this?
I'll think about it.
Coffee's coming back. I'm gonna pay for it now. Oh, we're still recording, aren't we?
Yeah, we're still recording.
Yeah, nature's put.
You need a bathroom? Okay. No, the next two slides, let's not worry about the pathophysiological mechanisms for these two slides, because we're going to go over the pathophysiology of each topic. Okay, so let's not worry about that right now. Now, stomatitis. Stomatitis, this is inflammation of the oral mucosa. They give you there the causes. I had a picture of it. I won't have the picture on the test, so don't worry. But if you were to look at, yes.
So should we cross those two slides out?
Yeah, just cross those two slides out.
Yeah.
That's not necessary for right now, because we'll go over the patho in each section. So with stomatitis, if you were to see a picture of this, it will look like blisters, or sort of like blisters inside and outside the mouth. Okay, on the oral mucosa, and sometimes they can go inside. This can be from a number of things. Just to point out, sometimes nutritional deficiencies can do it. Yes, chemotherapy and radiation. As we know, with chemo and radiation, it's one of those things that will definitely target our rapidly dividing cells, so it will definitely harm the epithelium. Chemical irritants, trauma. Now, they give here that they do have a type of stomatitis that is associated with herpes simplex type 1. Okay, so if you want to jot down, they're talking about type 1 here, as we all know where type 2 is located. Now,
Can you repeat the name again?
with this one,
Something with the
Herpes type 1.
oh, herpes simplex type 1. Herpes simplex type 1. Now, to say that about type 2, from my understanding, if someone has type 2, it can convert to 1, but 1 does not convert to 2, okay? So I just want to clear that up. So sometimes if a person has type 1, can they have an outbreak here? Yes. Excuse me, type 2, and convert to type 1 and have an outbreak around the oral mucosa? Yes. But if a person has type 1, that does not mean it turns into the STD format of type 2, okay? So in any event, this is what we call the cold sores, okay? Usually that individuals that do have this type 1 can sometimes feel the beginning of an outbreak, so it'll feel like a tingling sensation before the blister actually comes out. They do call this associated with cold sores. It is associated with fever and pharyngitis, okay? So this is usually accompanied with an actual cold virus most of the time. And they do have medication for that. Treatment, they say, is to just keep the area nice and clean. And also medications, they do have antiviral meds for this, which is Valtrax and some other, you remember all those commercials they used to have?
Once a day,
Yeah. Skipping on the beach. Okay. So, they do have medications to take care of that. Now, Gerd.
Would you like this?
You have Gerd?
No. We presented Gerd.
Oh, you presented Gerd. Oh, okay. Okay, now Gerd, I think we all know this disease, okay? And if you remember, Gerd is what we call gastroesophageal reflux disease. So the main problem here with Gerd, I do want you to understand, is sometimes people go straight to, okay, the causes, you know, they go straight to the spicy foods and the caffeine and all that stuff. But it's not so much of that. The cause here with Gerd, the issue is that the lower esophageal sphincter is not closing all the way, okay? Now, because the lower esophageal sphincter is not closing all the way, we do have certain risk factors, such as the types of foods and different activities that go on, that can now obviously increase the acid production, okay, and cause this issue. But keep in mind that the physiology of this, or the main issue, is the fact that the lower esophageal sphincter is not closing. So when that lower esophageal sphincter does not close properly, it will obviously now release, or that gastric juice in the stomach, up into the esophagus. And just to give you a visual, if you were to just imagine the stomach, and when your body's trying to digest food, the stomach has food inside of it, you have gastric juice, you have the chyme, everything's mixing through, okay, and it sort of looks like an ocean wave moving back and forth, okay? So it's actually a lot of movement going on in the stomach, even though you don't feel it as much, but there's a lot of movement. So if that sphincter is open, it's very easy for, when that propulsion and retropulsion happens, for that acid or that contents of the stomach to just go back up into the esophagus, okay? So that's what happens there. It can cause ulcerations in the esophagus, scarring, and all types of things. And we'll get into Barrett's esophagus in a little while, because that's another type of disease. Please keep in mind that the esophageal epithelium is not thick enough to handle that type of acid. The stomach is, but not the esophagus. Okay? And the reason why the stomach is able to handle that type of acid, and we'll go over this with ulcers again, the stomach actually has a very thick alkaline layer. So you can't have an acid on the, you know, and the stomach can actually hold an extreme amount of acid, as you know. Stomach acid is about pH 1 or 2. Okay, so please keep that in mind. And the esophagus is not equipped for that. So it will actually start to burn away that epithelium. So, causes here. Number one cause, as we know, is the failure of that lower esophageal sphincter to close. Fatty foods. Now keep in mind, all of these other things will sort of increase acid production. Okay, so not that it's causing the GERD itself, but it increases its acid production. So fatty foods, caffeine, okay? Believe it or not, people don't realize coffee is extremely acidic. Okay, some people don't realize that, but coffee is very acidic. Large amounts of alcohol, as you can imagine. Smoking, sleep position, and I believe the sleep position is if you're, I can't remember which position it is. I think if you're lying flat. And that's why they tell sometimes people with GERD to sit up when they're having that issue. And certain drugs, believe it or not, certain medications can cause individuals to have an increase in acid production. Okay. One person, I don't know if it was in this class, but I think somebody was already the LVN, and they were saying, they gave a percentage of, the percentage of patients that you guys will be treating will have some sort of GI disorders. Just because of the simple fact that most of the medications do give GI disorders, unfortunately. So this is something that you guys will be working with years on. Now, another thing that we're going to go over too is hiatal hernia. Okay, I don't know if you remember what hiatal hernia is, but this is actually when the diaphragm actually just kind of weakens, and now has an opening for the hiatus, and then the stomach can actually push up, okay, into or above the hiatus. So this is an issue here, and this can also, obviously, if the stomach pushes up, okay, up into the esophagus, obviously that will cause GERD, which is up into the hiatus. And I'm going to go over that with you in a little bit, so if you don't get it. Okay. Barrett's esophagus. So this is something I want you to kind of highlight. And with Barrett's esophagus, this is what happens. Say, for example, if you have a patient with GERD, and they have GERD that's sort of, let's say, uncontrolled GERD, okay, that's not being treated. This can now cause a lot of acid to splash up into the esophagus and now change the epithelium of the esophagus. Please keep in mind that this is what we call a cellular adaptation. I will jot that down if I were you. Please write that the cellular adaptation here is what we call a metaplasia. So the cellular adaptation that occurs with Barrett's esophagus is a metaplasia. The reason why I'm telling you to write this down is because when we get to the final, I will have certain diseases, and a lot of these diseases, especially when we get into respiratory tract too, has a lot of different cellular adaptations. Okay, so I want you to know which one's a metaplasia, which one's a dysplasia, and so forth. So what happens here, the complication when columnar tissue replaces normal squamous epithelium. Okay, the issue here is that when it turns into a metaplasia, what is the next thing from a metaplasia? A dysplasia. And we know that a dysplasia is something that's preneoplastic. So what will happen here, this puts these patients at a risk for esophageal cancer. Okay, so not to say that they have esophageal cancer at this stage, but they really have to be monitored to make sure that it does not turn into a dysplasia. So I do have a video. I'm sorry, I didn't pull up, and I do want to show you this quick video about that.
It's on tonight.
What's on?
The Victoria's Secret's bag.
Oh, yes.
Watch it. I would be too busy watching shots.
I'm sorry.
Don't hate.
Go ahead and say that in the camera.
I don't know why I don't understand.
The bottom, on the bottom right.
It is, yeah.
You have to turn it on down below you.
What?
Yeah. I'm sorry.
Who was that? Thank you.
I know.